Hi, everyone. I'm Dr. Bonner from Pain Consultants USA, and we're back for another episode after a little hiatus. And today, Dr. Connor and I are going to speak to you about common side effects that might occur after a steroid injection, which is a common procedure done for painful conditions. So, we're going to get into it here a little bit and talk about different things that can happen after you have one of these procedures. Dr. Connor, how are you doing today?
Not too bad. You staying safe down in Florida?
Yep, doing just fine here. Quarantining and social distancing as appropriate. And it's about all we can do.
Yeah, we're all in the same boat here. So,
Yeah. So, a common question we get asked is what are the possible side effects that can happen from some of the procedures that we do? And most commonly, we might be injecting a steroid or cortisone type medication into a patient, whether it be around a tendon, into a joint, around a nerve, to try to help some type of painful condition. And so it's a common question we have to answer. And I think that patients would benefit from hearing from us what is a good answer to that question. So, do you have any initial thoughts about what you say to that type of question?
yeah, so I always break that down into two groups, right? General steroid side effects or potential, and then more kind of procedure specific, depending on the area we're injecting. So, if we wanted to kind of just talk about steroid side effects in general at first, right? So, the obvious one that everybody thinks about, it could temporarily elevate your blood sugars. So this is, a big deal in diabetics, especially diabetics that are poorly controlled or oftentimes will have high blood sugars during the day for whatever reason. So blood sugars an issue. People who receive repeated steroid injections, thinning of the bones or increasing the risk of something called osteoporosis is another potential. High blood pressure, like elevations in blood pressure itself from the steroid, we could go into maybe not as common, but is a potential risk. A lot of talk right now in the current situation with infection, right? Does steroid increase the risk of infection or decrease your abilities or your body's ability to kind of treat infection? So those are some of the most common ones, I would say. We
Yeah.
talk about like repeated use, maybe like, weight gain or cataracts or different issues.
Yeah. So I would just say, sometimes we can break those up into, and you talked about some of this, but we can break it up into kind of short term versus long term. So if you have one steroid injection, which many people have one steroid injection at some point in their life, or maybe take a week of steroids for some type of condition. A lot of people take steroids for lung problems and lots of other issues that are unrelated to pain. But if you take steroids once in one injection or 1 week, what are the things that can happen? Like you said, blood glucose can go up, blood pressure can go up. Sometimes people's faces turn red. You get facial flushing, and that's a common one. And I always mention that one because a patient will call and say, "Oh, my face turned red," and it's like, well, we expect that. So it's not uncommon. You can get a headache kind of associated with that. Um, if it is an injection, the other thing that sometimes we see is you can get changes in your skin pigment. That tends to be probably if it's more towards the surface, more towards the skin. I don't think that I see that too often, but that can happen. And then the other one can be probably more if you're taking oral steroids, would be gastritis, would be kind of irritation of the stomach. But you can, I think, also get that if you get a steroid injection, especially if you're taking some anti-inflammatories alongside that. And then when we go to the long-term ones, and that's more, the other one that I get asked about that I don't think you mentioned is weight gain. I have a lot of patients where I always say, no, I don't want a steroid because it's going to make me fat. It's like one injection, probably not going to have that effect on you. I think sometimes people may notice that they gain a little bit of weight and there may be some type of kind of fluid retention effect happening. And so the steroids causing you to retain some more fluid than you typically would have. And so you gain a couple pounds, but that should go away when the steroid effect wears off and then you kind of diurese that fluid out. But definitely can be an issue if you're getting repeated steroids for many months, or some people get it for years and years for different conditions. And then also with that weight gain, it's sort of a change in the distribution of where that happens. So people get like a big, large face. They call them moon faces, like a big round face. And then also you see people get like a buffalo hump, kind of fat pad on the top of their back up there. This is concerning. If you're getting so many steroid injections that's really happening to you, you really want to tone that back. So that would be really concerning finding. And one of my goals is always to try to alert people up front. Look, this is not something that we can do over and over and over again. We try to target some site very specifically because we don't want to have to do it over and over again. If it works, but very temporarily, I wouldn't repeat this again or I wouldn't repeat it many times because of these possible issues related to long-term steroid effects. So I don't know what you think about that.
Yeah. I mean, again, one or two, not that big of a deal, most likely. I would say probably the biggest issue would be the blood sugar in diabetics. Just having a spike in your blood sugar. If it gets up into 3, 4, 5, 600 in some kind of type 1 diabetics, obviously that may necessitate a trip to the ER or other issues. So that's probably the biggest kind of risk, most serious one with one single type injection or acute use of it.
Yeah. Do you have a specific kind of like number that you have people look out for with that?
Usually we utilize like 200 or below as kind of a standard cutoff that we'll use before a procedure. Mm-hmm. Now, again, is there some wiggle room in there sometimes? If you're not NPO for a procedure and, patient checked their blood sugar and it was 100 in the morning and then an hour and a half later they ate something with sugar and then we checked it half hour later and it's over 200, as long as they're not on insulin and, maybe in those cases we'll let that slide a little bit, but for the most part, try to keep things under 200 before a procedure.
Yeah.
How about yourself?
I mean, definitely before in that range. And then after, it just depends on the patient. Some patients are, very good. They're like, oh, I check my sugar 4 times a day. I'll let you know if anything's wrong or if it's different. Some people who are more the type 2 diabetics, a lot of times they're like, oh, I check it once a day. And it's pretty controlled with like one medication. So those people usually aren't too concerning. They're probably not going to get too out of control with one steroid injection. So, but generally I tell them if they ever see above 300, definitely like give us a call or give their primary care physician a call to check and see maybe they need to take more insulin or take an extra dose of their medication to kind of bring it back down a bit. We definitely don't want it sitting up higher for a longer period of time, and we definitely don't want it getting any higher than that. Like you said, over 400 would be really concerning, and so we don't really want to get into that area.
I always tell patients the day of like a steroid injection, or if they're taking something by mouth for a couple of days, these are your sweets or your soda for the next few days, right? So you just have to, don't kind of follow your same diet if that diet raises your sugars to begin with after a steroid injection as well. I mean,
I like that. Actually, I like that. I'm gonna start using that. I'm gonna say this is your training for when you stop consuming sugary beverages.
There you go.
Because then your diabetes will be under control in the future, and you may not even need those medications if you stop consuming these things that are requiring the medication. So I like that. I'm going to use that definitely.
Just a quick side note, right?
Yeah.
I mean, with nerve pain too, poorly controlled diabetes, oftentimes pain can be worse, right? So just a side note, with certain kind of nerve type pain issues, if your sugar is not well controlled, sometimes that'll aggravate the pain.
Right. I think we talked about polyneuropathy before, and the number one cause of polyneuropathy in the United States is diabetes. And so we know that diabetes affects the nerves, and if you want it under better control, you got to control your diabetes. And we'll go back to that. To control diabetes, don't eat sugary or carbohydrate loaded foods. And if you have more questions about that, talk to your endocrinologist or your primary care physician. So, those are the common things that we see with steroids. And so those longer term ones are concerning. At times they can be pretty serious. We don't want to be making people osteoporotic. Osteoporosis is reduced bone density so low where you're at significantly higher risk of fractures with really minimal or no trauma. I think a lot of people who are very anti-steroid, a lot of physicians who are anti-steroid would say that you can really affect the bone density with just one injection of steroid, and that may be true. I know there's been studies that have shown kind of if you've had one steroid injection, it increases your risk for an osteoporotic or a fragility fracture kind of within the next year or 2 years. And I don't know all the details of that, but it's just another reason to, especially if you're kind of in the older 60, 65 and up age range, you kind of want to be avoiding steroid injections if you can. And then, if there's other treatments that work for you, great. And then if you can't, well, get one and make sure it's in the right place and make sure it's done appropriately and see if that helps you. And then the other one you mentioned was immune suppression. That's a big one now, especially with the coronavirus pandemic. Everyone's been talking about how important it is to have a strong immune system right now. So we don't know the effects. If you get a steroid injection, is that going to make you more likely to have a severe course of the coronavirus if you get it? Is it going to make you more likely to die if you get it? I don't think that we have really any idea about that. I don't know what you think, but theoretically the risk is there. If your immune system is suppressed, maybe you have a worse course, and maybe you're subsequently, don't do well because you got a steroid injection.
Yeah, I always tell patients there's studies out there and there's data to support if you're on oral steroids for, say, a week or two. I mean, we can see changes in lab values that we can possibly correlate to, okay, well, if these lab values are changed, maybe your immune, system might not be operating ideally. To my knowledge, there's not those types of studies with either a injectable steroid, once or even, repeated. But we're just using common sense right now. And again, higher risk patients, we're trying to minimize exposure to steroid if possible. Then the argument is, well, if you give them a steroid because they're in acute pain to minimize a trip to the ER, try to weigh risk benefits as well. So,
right. I mean, this is what we do all day, is weigh risks and benefits of everything that we do. And that has to come into our decisions at this point. I'm weighing risk and benefit now of every day, which patients come into the office to see me and which ones do we just do through a telemedicine type visit. Because, a lot of visits, it's just not worth the risk. Definitely if we're treating some painful condition and you're better, it's not worth the risk of you coming into the office to say, hey, I'm all better. Okay, great. Like we'll talk to you through the computer or through the phone. Great, you're better. let us know if anything changes. But, that's risk and benefit is kind of what our job is all about, everything that we do. And that's just the coronavirus is kind of making that even more complicated now.
I would just go back to the osteoporosis for a second, because I feel like this is something that is probably glossed over a lot or forgotten about in patient care on a pretty uniform basis, and it's no one physician's fault necessarily, but when you're seeing your family doc or other specialists, there's a lot of different moving parts to a visit, and sometimes bone health gets kind of forgotten about, especially if blood sugar or blood pressure isn't controlled on that visit, and we're working on that. But you should always be screened, right? I think women over the age of 65 should at least have a DEXA scan. If you're at higher risk for potential fractures, the guidelines are to have a DEXA scan even earlier. But really, osteoporosis due to glucocorticoid exposure is a cumulative effect. So if you're getting steroids from different physicians, whether it's for your asthma, then you have a sciatic issue and you're seen somewhere and they give you oral steroids, and then you see a provider who's going to give you an injectable steroid. And patients can be exposed to a lot of steroid pretty quick and in a short period of time, and that adds up over the course of months to years. So it's always important to get a DEXA scan. Again, people who are at risk too is Caucasian females, thin, over the age of 65 or postmenopausal, especially smokers as well. So
yeah. One point that I always find interesting and glossed over, just like you're talking about, is you find some people who have had a previous fracture in their spine, what's called a compression fracture, and they've had treatment for that and it's all better, but you just routinely kind of see it on an x-ray and you say, well, how did you get that? And they said, oh, I don't know, like it just happened, or I bent over and all of a sudden I had back pain and they found the fracture. And so if you have a fracture that is kind of a non-traumatic fracture and you're osteopenic, so when we measure bone density, we see kind of normal. We see osteopenia, which is low bone density, but not in the osteoporosis category. And then we see osteoporosis, which is very low with significantly increased risk of fractures. So if you're in the osteopenia category, but you've had a fracture like this, a fragility fracture or a non-traumatic compression fracture, you are osteoporotic, regardless of what that test shows. So if that bone mineral density test shows that you're osteopenic, that doesn't count if you have a fracture already, and you should be getting treatment for that. So some people get a spine compression fracture, they get a treatment called a kyphoplasty where they put cement inside the bone, build the bone back up, it takes their pain away, but then they don't get the treatment for osteoporosis, and so their bone mineral density continues at the level that it was at. It may get even lower, and then they're likely to have more and more fractures. So if you've had one of these fractures, you likely need to be on some kind of treatment unless there was a significant reason for the fracture. You fell off a roof and landed on your butt and you got a compression fracture in your spine. Fine, you're not osteoporotic, you don't need that. But we need to think about that the bone mineral density test, the DEXA scan, it checks a few places in your body for your bone density, typically the hips and then the lower lumbar spine, and then sometimes they do like the wrists, but it doesn't check your T10 vertebra, and that bone could be osteoporotic without other bones being osteoporotic. There's also things that kind of get in the way of the density test, the DEXA scan. If you have too much osteophytosis, or maybe we call it arthritis in the spine, that can make the test kind of falsely negative. So you just have to be careful. I see a lot of patients who are older who have had a spine fracture are not on treatment for osteoporosis because they say, no, I don't have osteoporosis. If you have that fracture and your bone mineral density is low, you are osteoporotic until proven otherwise, and you should be on treatment to prevent further fractures, right? The point of treatment for that is to prevent fractures from happening again in the future, okay? It's not sometimes we can build bone back up. There's one probably specific treatment that can do that, and we could go into a different podcast about this. But the point of the treatment for osteoporosis is to prevent future fractures. Fractures hurt really bad a lot of times and can be very disabling, and so it's important to prevent fractures from happening. All right, that was a little tangent there, but I think it was important. So then the steroids are one of the most common things we get asked about, and those are kind of the common answers. The other thing that can cause a problem when you're doing a procedure is just doing the procedure. And, the most common reaction from the procedures that we do would probably be, just some soreness at the site of the procedure. Obviously, if we're putting a needle into the skin, we're going to probably cause a little bit of soreness. We're injecting some medications that might kind of be compressing some tissues when they're injected, or kind of spacing out some different tissues. So, that can be painful. So there's probably going to be some soreness most of the time. I don't know what your experience with that is, Dr. Connor.
Nobody's ever sore after all. Yeah,
you
no,
must have fantastic hands, huh?
Yeah, we used the tiny needles.
Yeah.
But yeah, a little bit of soreness, is common. I think most people understand that that's once the lidocaine wears off, that's usually par for the course.
What's your typical needle gauge that you would use for for an injection into, say, the knee joint?
I use a 25 gauge.
Okay, yeah.
Most of the time, I don't numb the skin or even use that cold spray.
Yeah.
Most 25 gauge is usually well tolerated.
Yeah, I agree. I think it's very well tolerated. And a lot of patients like the cold spray. A lot of patients ask for the cold spray. It's probably not necessary. The coldness of it probably hurts as much as the little pinch that you get from the needle. But I use it generally if patients ask for it. And if they don't ask for it, I don't tend to use it. And I don't think it changes the tolerability of the procedure at all. Yeah. Other side effects we might see from a procedure would be like a vasovagal type reaction. You want to talk about that a little bit?
Well, that is kind of in layman's terms, usually patient getting an injection and then you feel like you're going to pass out, or you get the cold sweats and kind of heart rate drops, and you feel clammy, cool, and you don't feel well, maybe nauseous as well. That's a vasovagal response. You don't see it all the time, but it's a pretty classic presentation when you do see it. Most patients kind of give you the heads up that, they're not feeling that well. And typically, you just stop the procedure or injection. You can lay them on their back, elevate their feet, maybe a little cold pack. And usually within a couple of minutes, people are feeling a lot better.
Yeah. Yeah. From our standpoint, if the patient's kind of like on their stomach, sometimes you just see the sweat start to pop out of their back all of a sudden. And you're like, are you feeling okay? And they're like, no. And you're like, okay, well, we're done here, So from our standpoint, that it's concerning, but all we do is typically kind of end the procedure. Like Dr. Connor said, if you're not laying down already, get you laying down. If you're laying down, we can tilt the table so that your head is down and kind of get some blood rushing back to your head, because it's a reaction where kind of your blood vessels tend to dilate and the blood kind of pools in the blood vessels. And so the blood's not circulating well. And so since the blood pools in your blood vessels, it doesn't go up to your head. And so you feel like you're going to pass out. You're not getting enough blood up into your brain. That's why we just use gravity to tilt you down, get some more blood up into your brain, put your feet up in the air. Helps with the same thing, drain the fluid out of your legs and back up towards your head. And like Dr. Connor said, after a little bit of time, usually the patient will come around. I don't see this too often, but and I've seen different kind of rates that it may occur in a lumbar spine procedure. It might be like a couple % of the time. And it just depends on the patient. And sometimes you'll see a patient who says, look, this has happened to me before where I passed out when I got an injection. I had a patient say this. And I was like, okay, well, I don't know what happened. It was 20 years ago, but we'll try it again. And we did an injection, and she passed out on the spot. So, there may be people who are kind of more prone to it based on, anxiety about the needle or something like that. But it can happen. It's not too concerning. We just kind of respond appropriately, and the patient usually comes around just fine.
Yeah, most of those patients, if going into it, maybe like you give them a small pill of a medicine to calm their nerves ahead of time, or those might be the cases that we may bring to a surgery center where you can get a little bit of light sedation through an IV just to kind of take the edge off and make everything a more pleasant experience.
Yeah, good point. Another thing I like to talk about before I do any procedure is that the procedure could make the pain worse. So sometimes this happens, and this is never the goal of the procedure, but occasionally this happens where I do a procedure and you get worse. And I don't ever like it to happen, but it can happen. Sometimes we probably don't know exactly why that happens. Sometimes we may be able to infer from where the procedure was done. Oh, we might have gotten a little too close to this nerve, or the medication kind of squeezed the nerve because the space around the nerve wasn't very much. But that can happen. I think it's very important to mention that because some patients aren't aware that that's possible. Do you talk about that too?
Yeah, I mean, anytime you put a needle through skin, like we said, infection, bleeding, more pain. And again, depends on the area where you're injecting. I mean, from personal experience, when my shoulder, have gotten that injected before, for a week afterwards, it felt way worse than it did prior to the injection. And then things kind of calmed down. It is tough to know exactly why. I mean, you could theorize maybe like the particles within the steroid. Sometimes when you use contrast, I mean, some people think maybe the contrast, the dye actually could aggravate things. So it's tough to know, but I mean, it can happen. The good news is almost always, if it's a typical kind of post-injection flare, that will calm down after a few days or a week.
Yeah, definitely. I think definitely within 2 weeks, usually it'll calm down. And if it's not, that would be concerning to me. I would kind of look further into that and see if there's something else going on. See, sometimes you could create a new problem with an injection. Very rare side effects would be kind of creating like a major bleed somewhere or creating like a large infection. And that's where you'd want to get some new imaging to see if that kind of collection is developing in there. And if you did see that, get that treated ASAP. But that would be very rare to have something like that happen. Something else you need to, oh, go ahead.
No, I would just add, if you're doing steroid injection around a tendon, worsening pain too. I mean, if the steroid was injected in the tendon, which you should never do, it could cause a tear of the tendon or additional weakening and small tears, large tears. So that might be another reason to have worsening pain.
Yeah, like you mentioned, a shoulder injection. I always warn patients, sometimes if you have a tear of a tendon, you may get worsening tear. Even just injecting steroid around the tendon, it may make that more likely to tear in the near future. And sometimes you'll see people where they've gotten an injection, and then within a couple of weeks, things got much worse. And then you get an MRI and you see like kind of a massive tear of a tendon, either the biceps tendon or the rotator cuff, and you wonder if the steroid had something to do with it. So I always, kind of warn, like if we're concerned about a tendon tear here, we really want to stray away from an injection in favor of some other treatments first, or we do some imaging to ensure there's not like a large tear associated with the pain that you're having.
I would agree with that.
Okay. One thing you need to be concerned about with any medication is an allergic reaction. So typically the medications we're injecting are some type of local anesthetic, some type of steroid, which would be, or cortisone. Common ones would be Depomedrol, Kenalog, which are like methylprednisolone, triamcinolone. There's lots of long, complicated names for these things. But you just need to know if you're allergic to any of these medications. The other thing would be the contrast agent that we're injecting. So some people who are allergic to iodine, you may be concerned about specific contrast agents that contain iodine. So, and then some people, I think I don't know if there's clarification on if you have a shellfish allergy, does that make you allergic to iodine? But that's what people always think. So
I think that's been debunked.
Yeah, I think that's debunked, but people always still bring it up. So I always just respect that. If some people say, "Oh, I can't have iodine. I'm allergic to shrimp or something." It's like, okay, well, we'll try to respect that and see what we need to do. See if we need to use the iodine, or can we treat people before that. Yeah. What was that?
No, and then some of the contrast mediums are non-iodinated, so
right.
Most of the time that's what we're using nowadays.
Yeah, exactly. Good point. Anything else that you talked to patients before about steroid injections?
I mean, the one other would be specifically, when we're injecting into a joint. Joints have cartilage, right? So repeated steroid exposure, even one steroid injection into a joint, puts you at risk for kind of cartilage degeneration. And most of the time we're putting steroid in a joint because the cartilage is already degraded and you're dealing with osteoarthritis. So steroid can make that worse over the long term, right? So repeated steroid injections into a joint is not always an ideal thing. Most people know kind of this rule of three where, no more than 3 injections into an area for the year. But not really sure where that came from, but minimizing exposure to the joints is always important. There are some other options when you talk about knee injections. The one caveat or one special thing to consider too is steroid in the hip, right, can put you at risk for something called avascular necrosis, where the blood supply to the hip kind of fails, and then the bone will deteriorate at a rapid pace and sometimes may require a hip replacement much sooner rather than later, and a lot more pain afterwards. So those are things with patients, especially when we're talking about a hip injection. I'll go over that with patients. If, sometimes we'll do diagnostic injections, right? Or we're trying to figure out, is this back versus hip causing the pain? So sometimes if we're not entirely sure and I'm looking at the hip first, that might be a reason to do a diagnostic only injection where there's no steroid, just anesthetic, it's to minimize risk of AVN, especially when we're not entirely sure if the steroid's warranted in the joint.
Right. And at the same time, there's research to show that the local anesthetics are actually toxic to the cartilage in the joints, which is very unfortunate. But many people have had local anesthetics injected into joints, shoulders, hips, knees, you name it. And I think the research that really showed that was more in like a petri dish. Cartilage cells were damaged or killed by local anesthetic in the region. So I don't know that we know for sure that it has that effect in the human body, but that's concerning. And so it's just another reason on top of what you mentioned to, as much as possible, limit injections with these medications as much as possible. So we definitely don't know everything about these injections. We know that lots of people get them. We know that they help some people. We know that they don't help other people. And it's really hard to predict who's going to respond to some of these procedures, I think. And so that's why it's really important for patients to understand the possible adverse effects that can happen with one of these procedures. What about anything else that you can think about that you talk about?
Yeah, I would say, again, site specific, but when you get into epidural steroid injections, which we've talked about before, but the type of steroid that's being injected is very important. And that's things I always urge my patients, or, if I'm consulting with a patient and they're going to be getting a procedure by a different provider, you want to know what's being injected inside of you as well. The three most common steroids used would be dexamethasone, Depomedrol, and then some people like a triamcinolone or Kenalog type medicine. So the main difference, right? If you see your doctor drawing up the steroid and it's like this white kind of appearing substance, right? That's a particulate steroid. So meaning when you look under a microscope, there's little kind of particles, right? You see little kind of chunks of things. Some of those particles, again, when looked under a microscope, they could be bigger than the blood cell, like a red blood cell itself. So the reason why particulate steroids in certain types of epidurals cause an issue is some of those little particles, when you inject it, can kind of get into little blood vessels, and then they could cause blockages. Compared to dexamethasone, which is clear, there's no particles. You can inject that into a blood vessel and it won't cause any issues because, it can't clog up anything. So, a general rule of thumb, if you're undergoing a cervical epidural, if it's via transforaminal approach or coming out where the nerve exits the spine. So if you're laying on your back and the needle's coming either on your right side or your left side of your neck, that should always be done with dexamethasone. If you're doing a thoracic or lumbar transforaminal, again, ideally dexamethasone. Some of the lower lumbar levels, like L5 and even into S1, some people will still use a particulate steroid. I tend to use non-particulate anymore. And then when we get into kind of interlaminar epidurals, which you did a video recently highlighting the difference there. Interlaminars, you can use particulate because you're not as worried about arterial blood supply. Again, I would say in the neck, I would feel more comfortable sticking with dexamethasone for interlaminar. In the lumbar area, you could use, Depomedrol or Kenalog, and that might be a reason why one injection might seem to work better than the other two, is some people just find better effects with one steroid.
Yeah, but I don't think we have, along the same lines, I don't think we have any evidence to show that one is really better. So you might as well go with what is probably the safest one. So that's a great point. So,
I agree.
If you're getting an injection in your spine, an epidural, and they're not using dexamethasone, you might want to just ask them why they're not using that, because we tend to think that is the safest medication to use for that procedure, and that will help avoid any of the really possibly severe complications of that procedure that involve, like Dr. Connor said, kind of clotting a blood vessel or something. So I think that's a pretty good overview. If you listen to this and have any questions about steroids or steroid injections, feel free to reach out to us on our website or at our email address, and we'd be happy to help you understand a little bit better. Or if you've had a lot of these procedures and want to know why they're not working for us, we'd be happy to help you understand that too. And we're hoping everyone is staying safe and healthy during the coronavirus pandemic. So we'll hopefully talk to everybody soon. Thanks.